I was recently observing the lobby of a small, high-end clinic in a quiet corner of Tokyo. The atmosphere wasn't what you'd expect from a healthcare system supposedly on the brink of a demographic time bomb. It was eerily serene. The soft hum of an automated check-in kiosk, a nurse speaking in the hushed, melodic tones of omotenashi, and a total absence of the frantic, crowded friction we've come to accept as the global standard for public services. There was no chaos, only a quiet, expensive precision. Then the headlines hit. Japan had just authorized a 3.09% increase in medical service fees, the most significant hike in over 30 years. To the casual observer in the West, this looked like a white flag. Financial analysts immediately began their familiar refrain about fiscal deficits, aging burdens, and the inevitable collapse of a shrinking nation. The standard advice was whispered from every corner. Import cheap labor, lower the costs, open the gates. But as I watched the staff in that clinic, I realized something the headlines missed. There was no protest in the streets, no sense of panic among the patients. Instead, there was a collective unspoken agreement. When I spoke to a local researcher about the hike, he didn't point to a spreadsheet. He pointed to the clean, graffiti-free streets outside and the high-trust silence of the waiting room. We aren't paying for a deficit, he told me. We are paying the premium to keep Japan, Japan. It's a startling reversal of the global economic script. While the rest of the world chases the immigrant temptation and the bargain of cheap outsourced care, Japan is doing something radical. They are choosing to pay a higher internal bill to keep their social fabric from fraying. This isn't a story of economic decay. It's a story of a nation choosing civilizational dignity over a low-cost, high-friction future. It makes you wonder, if the price of a stable, cohesive society is a 3% hike, why is the rest of the world so afraid to pay it?
And that profound strategic decision is really the core of what we're getting into today. That choice to prioritize social cohesion and what you call civilizational dignity over, standard market efficiency, it's why we're doing this deep dive. Because the Japanese healthcare system, it really is a global enigma. I mean, here you have a profoundly aging nation, immense demographic pressure, but the system itself seems incredibly stable. High quality even. And it delivers, according to OECD data from 2015, the highest life expectancy in the world, 83.9 years.
Okay, so let's really unpack that. The basic framework is fee for service, or FFS, which to a lot of people, especially in the West, is sort of the source of all problems, right? It's seen as inherently inflationary. It incentivizes volume over actual value. Yet Japan manages to control costs, they get quality, and they maintain this high-trust social contract you mentioned. So our mission here is to dissect the very specific, almost ingenious mechanisms they're using to control price, quality, and volume, all inside that FFS structure, and maybe more broadly, how they manage to resist that global pressure to just, import cheap labor to cut costs.
Right. And to really appreciate how sophisticated their solution is, we have to start with the fundamentals. There are really three core challenges that make healthcare policy difficult everywhere. I mean, everywhere in the world, regardless of the system.
And the first one is on the demand side, inelastic demand.
Precisely. When a patient is sick, when you're facing a serious medical crisis, your demand for care becomes completely inelastic. You just want the best possible outcome. Financial constraints, they just sort of evaporate at the point of need. If the price of a life-saving surgery doubled tomorrow, demand wouldn't drop. And policymakers have to manage that kind of bottomless demand.
And that second point, it speaks directly to that political and cultural choice we started with. That idea of an egalitarian standard, keeping Japan, Japan.
It's a social contract of immense difficulty, and especially in high-income nations. In a universal system like Japan's, the whole goal is that high-income and low-income citizens have to be equally satisfied with the same high standard of care. And this requires something really difficult from the wealthy. They not only have to pay more for the care of the poor, but they also have to willingly accept the same level of service. If the wealthy decide the public system isn't good enough and they all run off to private, unregulated options, the whole thing just loses its legitimacy. It loses political support, and then the funding dries up.
So the high quality we see isn't just a nice bonus. It's a structural requirement. It's what holds the whole thing together. If the service quality drops, the political consensus just breaks down.
Absolutely. And then the third challenge is on the supply side. The doctors, the hospitals, supply is flexible, and physicians have a lot of professional autonomy. And there's just no global consensus on what a doctor should earn. Should it be twice the national average wage? 20 times. And because costs for the patient are revenue for the provider, the system is always under pressure to inflate.
When you lay out those three challenges, you can see why systems everywhere, especially in the US, are just constantly chasing these new payment models, trying to escape FFS. But Japan, France, Germany, they stick with fee-for-service for their doctors. So how do they manage to control costs with all these problems baked in?
Their success really comes down to centralized, non-negotiated price setting. That, combined with this overarching concept of solidarity. Universal health insurance in these countries is, at its core, a commitment to solidarity. It's about redistribution and reciprocity as a form of social justice. And in Japan, this translates into a very strict commitment to uniform prices for the same services.
Uniform prices, so a national mandate.
Yes. Since 1958, they've had this single standardized fee schedule. They took a bunch of older separate schedules and merged them into one national price list. And the explicit goal was universal access and equity. The result is that every single service, from a simple checkup to a complex heart surgery, has one price. It doesn't matter if you're at a fancy private university hospital or a tiny clinic in a rural area. The price is the price.
And that's a core leverage, isn't it? The government has this power that systems based on fragmented negotiated prices just don't have.
Let's put some numbers to this just to get a sense of the scale. You said life expectancy is the highest in the world. What about the money?
So looking at that 2015 OECD data again, Japan had a population of 127.3 million. They spent about 10.9% of their GDP on health, which is, manageable. But here's the crucial part. Public expenditure accounted for a staggering 84% of that total. It shows you just how dominant the state's role is in funding it all.
That funding profile makes it sound like a totally government-run system, but the providers are almost all private. That's a really interesting tension. It is. Something like 80% of hospitals and 95% of doctors' offices are private businesses. But every single one of them has to rigidly adhere to those nationally set prices. It's a decentralized delivery system under what is basically a centrally planned financial dictatorship.
And that's what makes it so different. Which brings us right to the mechanism of that dictatorship.
Yeah.
The single payment fee schedule. It's not just a price list. It's more like the master legislative text for all of Japanese medicine.
That's a perfect way to put it. The fee schedule is published as this huge document. I mean, it's over 2,000 pages long. It's the operating manual for the entire medical system. It defines all the covered benefits. It sets the exact price for every service. And this is the most critical part, it sets the precise conditions you need to meet to bill for that service. Over 95% of a provider's total revenue comes directly from this incredibly detailed schedule.
The scale of it, 2,000 pages. That just signals an attempt at total granular control over everything a doctor or hospital does. Why so much detail?
Because that granularity is Japan's unique answer to the FFS problem. Traditional FFS is often criticized using the formula E equals P times V. Expenditure equals price times volume. If you fix the price, P, the only way for a provider to make more money is to increase the volume. V, you get supplier-induced demand. Japan knew this. So they don't just control P, they strategically control V by embedding volume and quality constraints right into the conditions for payment.
So a doctor is theoretically free to offer any service. But if they don't meet these very specific, sometimes non-clinical conditions attached to the billing code, they just can't get paid for it. It forces volume control at an administrative level before the service is even delivered.
Exactly. It's not about reviewing claims after the fact. The regulation is built into the fee code itself preemptively. It makes sure that if a hospital is going to offer, say, a complex service, they have to have the right infrastructure and staff to do it well.
Let's use the rehabilitation therapy example because it just illustrates this so perfectly. What specific hoops does a hospital have to jump through just to bill for rehab?
The conditions are extremely specific, and they target quality and resources directly. So, to bill for standard rehab therapy, a hospital has to meet two criteria at the same time. First, the facility requirements. The hospital must employ at least 5 full-time physical therapists, or PTs. And on top of that, they need to have a dedicated rehab floor space that's larger than 160 square meters.
5 PTs and a big dedicated space. That immediately stops smaller, less equipped facilities from just offering rehab to make some extra FFS money. It makes sure the patient is in a high-quality setting.
Precisely. And the second condition is all about the patient's eligibility, which is a pure volume control mechanism. The patient must have had their stroke or injury within the last 180 days.
Wow. So if you're 6 months and 1 day past your stroke, the hospital can't bill the insurer for that specific acute rehab code. That's fascinating. It focuses resources on that acute recovery phase where it's most effective, and it cuts off the long tail of low-value chronic rehab that could just become a forever revenue stream.
It manages the flow of resources. It pushes hospitals toward efficient throughput for acute cases so they can treat more patients within the fixed budget. It stops beds from being tied up by long-term, marginally effective care. And this whole approach, this rigorous systemic regulation, it requires incredibly high levels of trust in the regulator and just meticulous compliance from every single provider.
And that high compliance has to be rooted in some very strict rules for even participating in the system. If Japan is committed to that egalitarian standard, that civilizational dignity, they have to make sure the wealthy can't just pay to get around the rules.
The foundation of that trust is the absolute prohibition of balance billing. Balance billing, as you know, is when a provider charges the patient the difference between the regulated fee and whatever they feel like charging. In Japan, that's completely forbidden. If providers could do that, the whole system would break.
And how do they enforce that? What happens if a hospital decides they want to charge a little extra for, say, a faster diagnosis or something?
If the hospital gets caught balance billing or extra billing for things that aren't authorized, the consequences are immediate and severe. They have to pay back the entire amount they improperly billed, not just to the insurer, but also directly to the patient. And they have to do it retroactively for the last 6 to 12 months of claims. It keeps the pricing model intact.
And beyond just illegal balance billing, they also tightly regulate the legitimate uses of extra billing, right?
Yeah.
Restricting it to very specific non-clinical things.
Yes. Extra billing is basically restricted to only 2 categories. The first is extra charge beds. So premium rooms. Maybe they have a better view, a larger private bathroom. The patient pays extra for the comfort, but the actual medical service they receive is priced identically to the one in the standard ward. The second category is for new procedures that are still being tested for safety and efficacy.
That is such a brilliant way to handle innovation. A hospital can charge for a brand new procedure, but only if it's part of an approved trial. And the second that procedure is proven to be safe and effective, boom, it gets integrated into the 2,000-page fee schedule, and it's available to everyone at the standard price.
It creates this defined, transparent path from innovation to ubiquity. It prevents new, high-cost treatments from staying exclusive to the elite forever. The government basically guides the timeline and the pricing for innovation.
But, 2,000 pages of rules are only as good as their enforcement. How do they actually make sure that thousands of private providers are following these rules so meticulously?
This is where the high-stakes auditing comes in.
Yeah.
The ministry's regional offices conduct these very rigorous on-site audits. And these aren't just paperwork checks. They physically verify that the conditions for payment were met. They'll actually check, does the hospital really have 5 physical therapists on staff? Does that rehab floor actually measure 160 square meters?
So if some administrator just fudged the numbers and said they had 5 PTs but only employed 4, they're caught.
They're caught, and the financial penalty is immense. Like we said, if the conditions weren't met, the hospital has to pay back all the money they billed for that service, often for the past 6 to 12 months. I mean, can you imagine the catastrophic loss? If an entire year's worth of rehabilitation billings gets clawed back because you missed one structural requirement.
That clawback risk alone must make compliance a terrifying daily reality for a hospital administrator. It forces this culture of absolute meticulousness, and it makes public hospitals constantly compare their own performance against the private sector, which promotes this high standard of management everywhere.
And then there's the ultimate deterrent, the severe penalty for systemic fraud. If the inappropriate billing is found to be systematic, a deliberate attempt to game the system, not just an error, the hospital risks the ultimate penalty, losing its health insurance license entirely. And if you lose that license, you can't bill the national insurance system, which effectively shuts down your acute care operations. That structural enforcement is the real cost control mechanism in their FFS system.
That level of systemic risk management is just key. But even with fixed prices and volume controls, things can't stay static forever. Technology changes, the population ages, demand goes up. So the system has to go through this political pressure cooker of revising those 2,000 pages every 2 years.
And that revision cycle is just a masterclass in constrained political economics. It's a highly technical, intensely political negotiation that happens like clockwork every 2 years.
Yeah.
And it follows this strict 3-step process designed to make sure the national budget constraints are met.
Okay, let's walk through that process, starting from the top.
Step 1 is the political ceiling, setting the macro revision rate. The prime minister, at the very highest political level, sets the global budget constraint. This rate takes into account unavoidable cost increases, like new expensive tech, like MRIs, plus the volume increases from the aging population. This rate is the absolute cap for healthcare spending growth for the next 2 years.
And that's the critical difference. The spending growth is capped politically before anyone even starts arguing about individual fees. The doctors and hospitals aren't arguing about how big the pie is. They're arguing over how to slice it up, knowing the size is already fixed by the prime minister.
Precisely. So once that political ceiling is set, they move to step 2, revising drug prices. These are adjusted based on market surveys and the volume of new drugs sold.
And then step 3, the most contentious part, is the item-by-item zero-sum game.
Correct. Item-by-item revisions. The fees and billing conditions for specific services are adjusted, but here's the rule. Any cost increase in one area, say raising the fee for a complex surgery, has to be fully balanced by an equivalent cost decrease somewhere else. Maybe they decrease the fee for a routine office visit. And it all has to add up to meet that macro revision rate from step 1. It is a true zero-sum negotiation.
You can just imagine the intense lobbying. Someone's revenue is always being cut to pay for someone else's investment. The 2010 revision data has some perfect examples of this balancing act.
It does. Let's look at where they cut. They reduced the repeat consultation fee in clinics, dropped it from 710 yen to 690 yen. Now that's a small cut, just 20 yen per claim. But when you think about the impact, this is a super high volume service, over 63 million claims a year. That tiny reduction saved the system over 126 million yen. They're swapping high volume nickel and dime revenue for big ticket investments.
And where did that 126 million yen go? They had to strategically boost payments for complex, high-quality care to keep specialists from leaving or letting quality decline.
Right. That saved money was funneled into areas like arthroplasty, joint replacement surgery. The arthroplasty fees saw this massive increase, jumping from 265,000 yen to 398,500 yen. An increase of 135,500 yen per procedure. But even though that individual increase was huge, the overall impact on the budget was managed because the volume of those procedures was relatively small. This shifting of resources is the whole game.
So they're constantly cutting fees for common, high-volume services to finance necessary increases for complex, low-volume procedures. It keeps the total budget fixed while rewarding complexity and efficiency.
And you see this with technology too. Back in 2002, the revision rate was actually negative 2%. To hit that target, the fees for expensive diagnostics, specifically MRI scans, had to be cut by a massive 30% in one go. But even with that huge price drop, the sheer volume of scans just kept driving spending up, so they had to keep cutting the fees in later years.
This constant downward pressure, combined with the zero-sum negotiations, it must require a steady stream of savings from somewhere. And a lot of that seems to come from their unique approach to pharmaceuticals, the drug price mechanism.
This is probably the most innovative and also contentious part of the whole system. It's where the pharmaceutical companies are structurally locked into subsidizing other parts of the system, particularly doctor and hospital revenues.
Okay, explain how that works. How do providers profit from drugs when the prices are regulated?
They profit from the gap. So the ministry regularly does these volume-weighted average market surveys. Let's say a certain drug has an official fee schedule price of $10 a unit. Hospitals and clinics, they use their bargaining power to buy that drug at a discount, say for an average price of $9.
So the hospitals and clinics are pocketing the difference, that $1 benefit between the official price and the price they actually paid. That's a key part of their revenue.
Precisely. That spread is the structural incentive. But when the fee schedule is revised every 2 years, the ministry steps in. They set the new official price based on that average market price, $9, plus a small margin, usually around 2%. So the new official price drops from $10 down to $9.18.
The price just keeps dropping over time, and that difference is effectively captured by the government and then used to finance increases in doctors' fees or other things. It completes that zero-sum loop. So pharmaceutical revenue structurally goes down, and that money gets recycled into, say, higher fees for arthroplasty.
It shifts the burden. The pharmaceutical sector absorbs the price deflation, which lets the government maintain stability and quality somewhere else. It reinforces that commitment to their domestic workforce and high standards.
And all this intense bargaining balancing, 20 yen cuts against 135,000 yen increases, repricing the entire drug market. It all happens at the Central Social Insurance Medical Council, CHOKU.
Correct. TreeQ, which is part of the Ministry of Health, that's the arena for all this. Its meetings are public, and they have representatives from the payers, the providers, academia. But while the council figures out the technical how, the final budget targets are ultimately set politically by the prime minister. And that centralized political control is what makes the Japanese government's power so much stronger than, say, the self-governance models you see in France or Germany.
Okay, so despite the success of this really rigorously regulated FFS system, by 2003, there was still this internal pressure to change, especially for inpatient care. Why introduce a whole new payment model like diagnosis procedure combination, or DPC, if the FFS system was already so tightly controlled?
The payers, so the insurers and the government, they were still worried that traditional FFS was just inherently inflationary, especially for long, complex hospital stays. They wanted to bring in a bundled payment to incentivize more efficiency and shorter lengths of stay.
But the providers, particularly the big academic hospitals, they must have strongly opposed a standard DRG model, like we see in the US, where you get one fixed price per admission.
Exactly. They were afraid a fixed price per admission would just destroy their revenue predictability. And, it could even incentivize premature discharges or cutting back on necessary care. So Japan designed this uniquely Japanese compromise, the DPC hybrid. It was designed to control costs without totally sacrificing quality or provider revenue.
What were the key parts of that compromise that got the providers on board?
The design was very clever. First, the payment is per diem, a fixed rate per day, not a fixed rate per admission. That gives providers some stability. Second, and this is crucial to encourage shorter stays, the payment rate actually declines across 4 different periods as the patient stays longer.
So the hospital gets the highest daily rate right at the beginning when the care is most intensive and expensive, and then the rate drops steadily. That makes really long stays much less profitable. That directly tackles the long stay problem.
And on top of that, they were really strategic about what services were bundled and what stayed FFS. The per diem DPC payment is inclusive only for things that are easy to overuse: drugs, routine lab tests, and basic imaging like x-rays. But the complex, high-value, high-skill services, so surgeries, anesthesia, intensive rehab, artificial devices, all of that remained paid on a fee-for-service basis.
That is the masterstroke of political engineering right there. It means hospitals that specialize in complex surgery can maintain their revenue streams because the most valuable work they do is still paid FFS. They get the efficiency benefits of a bundled payment for routine stuff without losing the incentive for high-skill procedures.
It minimized the economic shock. And to make sure it was adopted, especially by those skeptical university hospitals, they added one more thing: the hospital-specific adjustment factor.
Can you explain that? It sounds like an initial revenue guarantee.
It was basically a safety net. So DPC was first rolled out to 82 university hospitals in 2003. And this adjustment factor initially guaranteed that the hospital would get the same revenue they would have under the old FFS system, even if the DPC calculation came out lower.
So if a hospital historically made $1 million under FFS for a certain set of patients, but the new DPC calculation only gave them $800,000, they'd get an adjustment factor of 1.25 to make up the difference.
Precisely. It ensured they could make the transition without immediate financial risk. It was kind of a bribe to get them into the new system. Now, that factor started to be phased out in 2012, and by 2018, it was gone completely. By then, the hospitals had gotten good enough at managing their costs that they didn't need the safety net anymore.
So DPC was introduced as this risk-free transition, but it forced compliance. What were the actual results once it was widely implemented?
The adoption was incredibly rapid and successful. It went from those initial 82 hospitals in 2003 to over 1,600 by 2016, covering basically all acute care in the country. And the system immediately led to this high degree of care standardization. It cut down on a lot of unnecessary variation.
Standardization in practice, not just on paper.
Exactly. For example, the sources noted that it ended the common FFS practice of giving almost every patient a daily antibiotic drip while they were in the hospital. Under FFS, that was a profitable, high-volume service. Under DPC's bundled payment, it just became an unnecessary cost. Clinical pathways became very popular as hospitals tried to be as efficient as possible.
Of course, hospitals run by smart administrators, and they quickly found ways to optimize or game the new payment model.
They did. Since the DPC payment only bundles drugs, labs, and imaging during the inpatient stay, hospitals found a way to boost their revenue. They started transferring procedures like CT and MRI scans from the bundled DPC part of the bill to outpatient care after the patient was discharged.
So they discharged the patient, bill the lower DPC rate for the stay, and then bring the patient back the next day for a non-bundled full-price FFS CT scan.
Correct. It allowed them to maximize the inpatient payment while still collecting that lucrative FFS revenue for post-discharge procedures. It just shows that even a centrally controlled, highly regulated system has to constantly monitor for this kind of structural gaming and adapt its rules every 2 years to close the loopholes.
This whole complex technical balancing act, fixing prices, controlling volume, introducing hybrid payments, it all happens without sacrificing that cultural premium we talked about at the beginning. They get standardization and efficiency, but they still deliver this service level that is just consistently above global standards. Which brings us back to the cultural anchor, omotenashi.
Omotenashi is foundational to that high-trust, high-quality equilibrium. It's often translated just as hospitality, but it's much deeper. It's defined as a kind of level 5 service, the art of anticipatory, top-notch service that pays attention to every little detail with sincerity, and it exceeds the prescribed standards. It brings unexpected value.
And how does that actually show up in a medical setting beyond just, hushed tones in the waiting room?
Well, it manifests as a sort of economic justification for the whole system. Because the patient accepts central price controls and limited choice, the system pays them back with quality of service. This includes really thorough, in-depth examinations that often take more time than in the West. It includes smart appointment systems to minimize waiting time, and just the immaculate physical state of the hospitals.
And the human element.
Crucially, the system emphasizes one-to-one private nursing, a really dedicated level of care. This lets patients arrive without relatives and still feel completely supported almost at home during their whole stay. This strategic preservation of service ethics reinforces that unique cultural identity and justifies the public's high trust in the system.
That high standard of omotenashi is so important because, as we get into compensation, that level of precision isn't necessarily matched by a huge financial reward, especially when you compare it to the U.S.
That's absolutely right. The regulated fee system successfully limits how much physician incomes can grow. Compared to their U.S. counterparts, Japanese physicians earn significantly less. For context, the average U.S. generalist in 2016 made around $218,000. The average Japanese physician, and that's both generalists and specialists, was much lower, around $124,000. The fixed prices keep salaries relatively constrained.
But even inside that constrained budget, there's a fascinating internal political dynamic that decides who benefits most from that zero-sum revision cycle.
This is one of the system's really unique political biases. In most other developed systems, like in France or Germany, specialists, your surgeons, your cardiologists, they tend to be paid more than generalists. It reflects the complexity of their work. Japan flips that. Private, office-based generalist physicians who are highly organized under the powerful Japan Medical Association, or JMA, they are actually paid more than academic hospital-based specialists.
Why does the system favor the generalist over the specialist in terms of pay? It seems kind of counterintuitive.
It's a purely political allocation of that finite pie. The Japan Medical Association has this historically close relationship with the Liberal Democratic Party, the LDP, which has dominated Japanese politics for decades. That political access gives them incredible leverage to advocate for primary care fees within that constrained zero-sum budget negotiation. They just have the political clout to get a bigger slice of the pie.
And we saw that link pretty clearly when the LDP briefly lost power, didn't we?
We did. The sources note that during that brief period between 2009 and 2011, when the LDP was out of power, the Ministry of Health immediately used a cut in office visit fees, which directly hit the JMA's constituency to finance increases in surgical fees for specialists. As soon as the LDP came back to power, that trend reversed. It just confirms that the payment structure isn't just a technical valuation, it's a direct reflection of who has the strongest political ties.
This entire system of cost control, political balancing, and high-stakes auditing has always operated under this assumption that budgetary constraint, driven by demographics, was the most important thing. But now we circle back to where we started. That 3.09% fee hike, it signals a totally new fiscal script.
It signals the government's recognition that you can't just squeeze the system forever without risking the very civilizational dignity they're trying to preserve. This new script is formalized in their latest strategy document, Hanamudo 2025, and it signals a major departure from their old cost control methods.
How does Hanabudo 2025 formally change that constraint model?
The change is revolutionary, really. Social Security spending will no longer be capped based solely on demographic factors like the aging trend. Instead, the budget guidance will now be guided by broader economic and price trends, including inflation and domestic wage increases.
That is a fundamental acknowledgement of reality. It breaks the old paradigm. It's an explicit recognition that years of successful cost containment have suppressed the wages of essential healthcare workers. And now they have to respond to inflation and the labor market. That 3.09% increase is the first tangible result of that.
Yes. The practical goal is explicitly to support significant wage increases across the healthcare and welfare workforce. The government is committing to raising official prices, but they're going to balance that with continued aggressive efficiency improvements. So the price hike is a strategic investment in maintaining quality by paying their domestic workforce enough to keep them in Japan.
But that perennial tension between innovation and cost control, it's still there, right? Especially with pharmaceuticals.
Absolutely. The Ministry of Finance is still pushing hard for further utilization of cost-effectiveness analysis, or CEA, to determine reimbursement prices. They really want to expand the scope of CEA to make pricing more rational and efficient.
The pharmaceutical industry must have pushed back hard on that.
They did. The initial draft used the much stronger word expansion when talking about CEA, which led to a lot of industry pushback. The final softened language, further utilization, it shows that advocacy matters, but the signal is still clear. The government wants to use efficiency analysis more in its drug pricing.
And on the other side of that, the government is also signaling it's willing to support domestic innovation more explicitly.
They're pledging to streamline the regulatory approval process to fix two big problems: drug lag, where new drugs take too long to reach Japan, and drug loss, where companies just skip the Japanese market entirely because the pricing is so bad. They're also looking at supportive pricing mechanisms just for patented, innovative products to try and incentivize those manufacturers to stay in Japan.
And beyond pricing and innovation, the system showed some real vulnerabilities during the recent global supply chain disruptions. Is Nabuto 2025 addressing that kind of systemic resilience?
Yes, supply stability is a huge focus, especially for the fragmented generic sector. The document talks about structural reform, specifically addressing the small-scale, multi-product manufacturing setups that have led to repeated drug shortages. They're prioritizing support for domestic biosimilar production and emphasizing workforce development to train and retain skilled pharma workers. This is about national self-sufficiency and stability, again, controlling their own destiny.
Finally, we noted the political landscape is becoming more dynamic. It seems like they need a broader consensus now on these really high-stakes policies.
That's right. The ruling LDP coalition recently lost its majority, which has increased the influence of opposition parties. And Nabuto 2025 actually incorporated several proposals from these opposition parties, like promoting regional formularies and reviewing insurance coverage for over-the-counter like drugs. It signals that future policy, even on these technical details, is going to require more political buy-in and compromise, which will make those tricky negotiations even more complex.
So we started with this surprising 3.09% fee hike, a decision that, global analysts saw as a sign of fiscal collapse. But after unpacking the sheer regulatory sophistication of this system, what's the final synthesis here? What is Japan's approach to healthcare?
The central narrative is that this strategic decision to pay a premium represented by that fee hike, it is not a sign of collapse. It's a calculated strategic investment in maintaining high quality, strict equity, and a cohesive social fabric. They use a system where prices are centrally regulated and volume is aggressively managed through these technical conditions. It's a political dictatorship over a private market. And they've successfully achieved their goal of high quality and high trust by imposing this rigid, centralized structure over a decentralized network, which ensures the wealthy have no reason to defect from the social contract.
Japan's ability to get the price right by imposing a global budget politically and then regulating not just the fees, but also the volume, by setting those precise, administratively verifiable conditions for payment, all while maintaining those exceptional standards of omotenashi, it demonstrates a remarkable and stable equilibrium built on the political will to prioritize social stability over unchecked market efficiency.